The broadcast is now starting. All attendees are in listen-only mode.
Hello, welcome to the What You Should Know About Diabetes webinar. Our presenter today is Laura Bingell, who's the nurse for the MFP program. You will see on your screen that you have the ability to chat or ask questions. If you have any questions during the webinar, please feel free to use those functions, and I will make sure Laura has is able to answer those questions. If you have to ask something out loud, if it's too complicated to write out, simply write that in the chat feature and I will unmute your speaker. So without further ado, here is Laura. Thank you. Laura?
Okay. Hello, everybody. Hope you're having a great afternoon. We are presenting, as Suzanne said today, what you should know about diabetes. Many of you are working with people transitioning out of skilled nursing, and many of these have diabetes, so there is a need for knowledge. So let's start with slide 1. Diabetes mellitus. 29.1 million people in the United States are diagnosed with diabetes, and it may show up as diabetes or diabetes mellitus or DM in their medical records. Diabetes is actually from a Greek word that means to siphon or to pass through, and mellitus is from a Latin word, so we have a hybrid here, meaning honey or sweet. So sugar actually passes through the system, making the blood and urine sweet, and that's where it got its name. It's estimated that 8.1 million people have it and have not been diagnosed yet. Either they don't know they have it or they haven't been to a doctor, so either way they're living with it without knowing it. And approximately 1.25 million American children and adults have type 1 diabetes, and a little further in the presentation we'll get into the difference between type 1 and 2. For our population, the prevalence in seniors is of particular interest. The percentage of senior Americans, 65 and older, is 11.8 million diagnosed and undiagnosed. This represents 25.9%. And all these statistics are from the American Diabetic Association and are quite new. So we are going to run across it with at least a quarter of the people we're dealing with. So in the next slide, you may wonder what insulin is. We'll cover some of the basics. It is a hormone that's made by the pancreas, and it allows the body to use sugar from the carbohydrates we eat, converts it into energy, or stores it for future use. It's the insulin that helps keep the blood sugar levels from getting too high or too low. And each of these conditions we'll discuss. So first, hyperglycemia in the next slide. When the body doesn't have enough insulin available, it can't utilize the sugar or the carbohydrates for energy. They are, as we mentioned, siphoned through the kidneys. It makes the kidneys work very hard and spills into the urine. The body's cells try to get the energy they need by burning fat instead of sugar, and this produces ketones, which maybe you've heard that. Ketoacidosis, a lot of people on the Atkins type diet are looking to achieve ketoacidosis. Well, not necessarily good for us, but in this case, the ketones build up in the blood and the urine. One of the ketones is acetone, and it sounds familiar to you maybe because it is a chemical that is found in nail polish. So that smell is what we can sometimes smell on people's breath when their ketones are high or they're suffering from hyperglycemia. So when they rise to an unsafe level, diabetic ketoacidosis can occur. And those symptoms are what we have listed in the slide there. Frequent urination, increased thirst, the fruity smelling breath, shortness of breath, but additionally abdominal pain, nausea, vomiting, even confusion. And if it gets bad enough, it can lead to coma and death. So the American Diabetic Association is very conservative in recommending that Anyone that's running over 240 for their blood sugar level, which the normal is between 80 and 120, usually not fasting, they're saying call your doctor for under 2 or for over 240. When you ask the physician, what should I call you for, the physician usually says over 400. So people end up in the emergency room and often have levels 600 or over, and glucometers typically will read up to 600, and after that will say extremely high. So the level is really personal. Some people have very high blood sugars and don't show some of these symptoms. There's no one magic number that causes coma and death. Everybody's a little different, so it's real important to monitor and keep them at a good level. So hyperglycemia itself is caused by not having enough insulin to process the amount of sugar that the body is challenged with. Perhaps a person ate more than they planned, or ate the wrong foods, too many donuts or too many candy, exercised less than planned, or has extra stress present from illness or the body's response to a new medication. In the year 2011, 175,000 emergency room visits for adults were generated by the condition of high blood sugar. So if a person's having a lot of high levels, they really need to discuss it with their physician and determine whether they need to change their medication, increase their medicine or insulin. They may get put on what's called a sliding scale to cover specific numbers, and the doctor may discuss compliance and diet with them as well. Prolonged elevated levels can lead to other life-threatening conditions, and it's very important to try to avoid these. So go ahead and go to the next one. We will break down now. Where did that go? Hypoglycemia. So you notice on the bottom of this, we have the same warning, can lead to coma and death. But some of the symptoms leading up to it can be a little different. Causes for hypoglycemia can be missing a meal, a poor appetite because of another issue going on, gastrointestinal upset, too many sugars in one meal, then a drop, or alcohol consumption that's immoderate or without food. So this can be treated, if it's not too low, pretty simply by consuming some carbohydrates. And this is why it's recommended that diabetics carry with them some hard candies or some juice or something of that nature, have it readily available. They can consume these and recheck their blood glucose after 15 minutes or so, and can even repeat. But again, if it happens too often, they need to be in contact with their physician to determine what they can do to maintain a healthy level. The American Diabetic Association recommends treating for anything lower than 70, but often people will present with reading in the 40s and not have any symptoms whatsoever. I have made a lot of phone calls to people after they had blood work and told them, your blood sugar is very low, how are you feeling? And they said to me, I'm fine. Why? So you just recommend to them that they make sure that they go eat lunch right away and include some juice or some carbohydrates in it. The glucometer will usually read down to 20, and then it says very low. And so again, there's no magic number. In the emergency rooms for 2011, 282,000 visits were attributed to low blood sugar. And this can often be confused, something you would want to know, with drunkenness, because it does affect a person's ability to concentrate, and they may be stumbling. So if they're diabetic and they're acting like they're a little drunk, you may want to consider if they have a low blood sugar. Okay, next slide, please. So the difference between type 1 and type 2 we'll discuss here. Type 1 is primarily children and adolescents, and it's because insulin is not produced. This has always in the past been known as juvenile diabetes. Only 5% of diabetics actually are type 1, and they often have other issues that are associated with what's causing their diabetes. They will have chronic issues with their eyes, kidneys, nerves, circulation, and healing. And In the long run, they are also at a higher risk of heart attacks, strokes, and problems with urinary and sexual function. They haven't really said what the genetic connection is, but the medical community does say there is a genetic predisposition. It tends to go in hand with genetic autoimmune syndromes, and the one that I found that comes up most often is autoimmune polyendocrine syndrome. And this is a syndrome where the body identifies hormones, any hormones, so it would affect the thyroid and adrenal glands as well, as intruders and destroys them and the glands that produce them. And this is why it may not manifest itself until adolescence, because these glands work for a period of time before they are utterly destroyed by the person's own body. And then by the time they're teenagers, they are no longer producing their own insulin and need to be usually on a pump. Okay, we can move on. Type 2 is the one we are more commonly going to see. It's previously called non-insulin dependent, and it really is a misnomer because a lot of these people are on insulin. It is usually adult onset, and this is why we've changed the terms to type 1 and type 2. So this accounts for 90 to 95% of all the diagnosed cases. It usually begins with insulin resistance and will progress to type 2 diabetes over time. In insulin resistance, muscle, fat, and liver cells don't respond properly to insulin and cannot easily absorb glucose from the bloodstream. So as a result, the body needs higher and higher levels of insulin to help glucose enter the cells to be used for energy. The pancreas tries very hard to keep up with this increased demand for the insulin by producing more, and as long as it's able to produce enough to overcome the insulin resistance, the blood glucose levels stay in a healthy range. But over time, this will lead to type 2 diabetes because the pancreas can't keep up with the body's increased demand. And without enough insulin, extra glucose builds up in the bloodstream, and that is what is diabetes. So it is medically managed by some of the strategies on the slide here: diet, oral medications, insulin, all three or a combination of them. And the risk factors for developing type 2 include aging, obesity, family history, inactivity, and ethnicity. There is a higher risk in this order for Native Americans, African Americans, and Hispanics to develop a type 2 diabetes. And yes, it is in that order. So it is helpful to know a person's ancestry as well to determine whether they're at a very high risk. Okay, let's see here. Okay, go ahead and move on. All right, associated risk factors with diabetes. As we mentioned with people with type 1, it also goes with type 2. However, the type 1 people have a longer period of time to develop it, since most of them have been dealing with diabetes from either childhood or adolescence. But high blood pressure, stroke, heart disease, they're often on multiple medications as well. And because of all the different problems they have, they really do need to be seeing their doctor on a routine basis to be screening for these problems so they can be identified early. The vision and blindness, the loss of vision, it's fairly common for people with diabetes to get what's called diabetic retinopathy. And this is actually a condition where the blood vessels in the eye become very weak and can even potentially leak. And so because of the buildup in pressure, it can also lead to glaucoma in people with diabetes. So they do need to see their doctor. They do need to be seeing their eye doctor as well. So as far as the poor healing of wounds, and in a previous presentation we dealt with wound and wound healings and mentioned that diabetics are at a higher risk of having wounds that don't heal well. In the year 2010, there were 73,000 non-traumatic lower limb amputations in the United States performed on adults aged 20 years and older, 60% of these were people who were diabetics. So the majority of them were related to the poor wound healing associated with diabetes. Other risk factors, I found this extremely interesting, was smoking. New studies have confirmed that smokers are 30 to 40% more likely to develop type 2 diabetes than non-smokers. And this is unassociated with any other risk factor, just that one risk factor alone. And people with diabetes who smoke are more likely than non-smokers to have trouble with insulin dosing and with controlling their disease. The more a person smokes, the higher the risk of developing type 2 diabetes. So just one other reason to encourage people to quit. Okay. All right, we can move on. Thank you. Whoops. Back to the RIP, please. Previous slide. Thank you. Diabetes is the 7th leading cause of death in the United States. And just to give you a few statistics, 69,071 death certificates in 2010 listed diabetes as the main cause of death. But the real kicker is that in a total of 234,051, it was listed as an underlying or contributing factor. So the person may have died from a stroke or a heart attack, but the reason they had the stroke or the heart attack was because of diabetes. So again, it has a major impact on the health of everyone. So let's get into management just a little bit here now, starting with some of the strategies: healthful eating, regular physical activity, monitoring of blood sugar, reducing risks, and then the different types of medications. With healthful eating, some people will need a dietary referral for nutrition counseling, and this could be helpful if this is done prior to a discharge. In an institution, people are provided with the meals that the doctor has ordered, and it may be a diabetic diet. So, of course, when people go home, the dignity of choice gives them the opportunity to eat whatever they want. However, we do want them to be educated so that they can make good choices. And then if they opt not to make good choices, it's because they were informed and it is their choice. We don't want them to be making poor decisions because they don't have the information. So dietary referrals are good if they're in agreement with that. Diabetes self-management classes are offered by many independent living centers and hospitals, and self-management classes are covered in certain instances by Medicare and Medicaid. So it can be looked into and can be really helpful to family caregivers as well in learning about the conditions of their loved ones. So we need to know ahead of time as well, especially transition specialists, how their medicines will be managed when they're home. Are they on oral medicines? Are they on injections? And the RRDC will be wondering, and they'll want to know, are they independent or do they need help? It'll make a difference what kind of services they need in their home. Okay. Diabetic meal plans. It's called these days now healthful eating and not diet, because diet has just become, it's no longer vogue and it's so hard. As far as healthful eating, we're just trying to be healthier. So making good choices, and it requires lifelong changes. And I included this slide because I thought portion sizes are so important, especially in our American society where everything has been supersized. And using the human hand is the ideal way to figure out a portion size, because each of our hands is personalized to us. So when you look at this, you can see that most of what you should eat is vegetables, proteins about the size of your hand, and fats, which would include butters and oils and those kinds of things, the size of our thumb. So it's really helpful to see what the portion sizes should be when people say, well, I don't eat very much, and then you see that they've misplaced the portions and the rice is the size of the vegetables or the fat is the size of the fruit portion. So this is just a very helpful way to keep track. The right meal plan can help improve blood glucose, blood pressure, cholesterol numbers, and it can help a person keep their weight on track, which would also help them in a lot of other chronic conditions. One of the big ones I'm thinking of, arthritis. So there are many home-delivered programs for meals and congregate meal centers. Many of them also have diets that are approved by the American Diabetic Association, or are called no concentrated sweets, and this can help someone to keep on track with healthful eating. Okay, next slide. Just to let you know some of the different types of meal plans people can have, and they don't have to be difficult. So I've got a comparison here for you. The carb counting. This is for someone who maybe wants to be really proactive and wants to keep track of everything, and it can be very successful for people. It's a very personalized thing, and each person needs to find what works for them. On the left-hand slide, much simpler, but can be just as effective. Creating your plate and dividing the portions into the sizes that are there. A small diagram can be left on the refrigerator, and it helps a person without having to do the math, without having to keep track on a piece of paper, just to be sure that they're eating healthy portions. And I really like that Create Your Plate because it is so simple and it can be very effective. So there's no one diet or meal plan that's going to work for everybody. The important thing is that it's tailored to someone's personal preferences and lifestyles and helps them achieve their goals. One of being keeping their blood glucose in a reasonable range. Okay, next slide. I thought it was a good time to mention artificial sweeteners because it does seem to be a very intricate part of most people's diets who have diabetes, because everybody likes things that are sweet, and for them sugar has become something they're not supposed to do a lot of. So there's all of this artificial sweeteners, and I just wanted to highlight here what the FDA actually says about aspartame, Splenda, saccharin. That includes NutraSweet, a lot of other ones as well. There's generic names and brand names. It's just like medicines. So medical research studies have shown that these sweeteners are safe for most people when used in moderation. So most people in moderation is pretty vague, but at the bottom, I'm a proponent that I always tell everybody, always be moderate in the use of everything. That's the safest thing to do. I can tell you from my personal experience that after not drinking diet soda like I used to, I felt better. Whether it's actually because I'm not having the artificial sweetener, I couldn't guarantee it. But if you have concerns, or if someone has concerns, it's always a smart thing to do a trial. Maybe go and just drink water, tea, and coffee for a week and see if you feel better. And if not, then it wasn't that. But if you're drinking 10 diet sodas a day, that's really not considered moderation. And the FDA is not guaranteeing the safety when it's saying safe for most people when used in moderation. And remember, things can change. Studies will change. 1 week eggs are good for us, the next week they aren't. And just need to keep up to date on our research. So there's a little bit of information about artificial sweeteners. Be advised. Next one, please. Activity level is always something that can improve a person's overall health. And the American Heart Association has and the American Diabetic Association, both of them, have starting walking programs that are available on their websites. This one I was able to put into a slide for you to look. And what the recommendation is 30 minutes of moderate to vigorous intensity exercise at least 5 days a week. Of course, we know a lot of our people have chronic health issues and weakness, and all kinds of other issues. The idea is a little is better than none. And you'll notice in week 1, it's just 5 minutes or 500 steps would be the first goal. So you start very slow. And as I said, a little is better than none. Start slow. And it's a good idea to have them just double check with their physician and make sure that they're cleared to do this. Many senior centers will have low impact exercise programs or stretching or other things like that. And some even will have water aerobics, that type of thing. So whatever's available in the community that a person can do, starting slowly and doing a little, is excellent. Next slide, please. Glucose levels would be, in our circumstances, monitored at home because that's where people are going. And so they'll likely have a glucometer that looks something similar to what we have here in the slide. And glucometers in the home are covered by Medicare, Medicaid, and private insurances as long as the person has a diabetes diagnosis. The doctor will give specific orders on how often they are to check. It may be once daily in the morning, twice a day, or before every meal. They may be on what I mentioned before, which is called a sliding scale, which means they give themselves insulin based on what their glucose reading is. If their reading is 100, the doctor may tell them not to take any. If their blood sugar is 150, then they are to take 5 units, and so on. So depending on how high it is, they would need more insulin to cover it. As I mentioned, glucometers usually read from 20 to 600, and then there's that period above or below, which is extreme. And for these, personal care aides can be trained to assist a person to do this. The doctor will usually tell a person to have a target range, and for diabetics, the target range is typically a little looser than what we would consider a normal limit, because we know it's going to be high. And often physicians are very happy if a person's after meal glucose is under 180. So for some people who are better controlled, they may want lower, and if the person can do that, it is by all means better for their health. In HbA1c, you may want some information on this. It is a hemoglobin A1c test, and it's a test that measures our trend over a 2 to 3 month period. So if the doctor orders this, he or she can look back and see how our sugars have been running over the past 3 months, whether they have been controlled or whether they have varied a tremendous amount. And this can help them to see whether the strategy they're using is appropriate for that particular person. A normal HbA1c is less than 5.7%. 5.7 to 6.4% is pre-diabetic, and over 6.5 is diabetic and likely poorly controlled. Next slide, please. Here is a list, and by all means not all-inclusive, of oral medications that may be prescribed for people with type 2 diabetes. As you see, there are a lot of them. These are pills that I have on this slide. I haven't included the insulin. So it's not always easy to tell just by looking at a medicine list or a piece of paper whether a person is diabetic. And in fact, I have had the experience of visiting one of our participants with a transition specialist who never thought to tell her he was diabetic, and well, he is. So if you have any doubts about what the medicines are for, Christine and I are always happy to review any lists for you with medicines or do some research for you. And there's always new ones coming out. So there's some that I came across that I was unfamiliar with that are relatively new. And you can either email us a name of one or fax us or email us the whole list, and we'd be happy to look through it. Because it is one of the things really that the RRDCs will want to know if the person is diabetic, because it does make a difference in the type of care and their risk factors that they're going to receive, and how much supervision they may need or help with their medications. Okay, go ahead. Insulin comes in several varieties. There's, as listed here, Humulin, Novulin, Humalog, Novolog, NPH, Velosulin, and mixes. It comes in different delivery methods as well. The insulin pen, which can be very helpful for people who can't see well or have limited dexterity, as long as they're on an unchanging dose. And it's very portable, so for a lot of people that works well. Then there's the vial and syringe, which is the old-fashioned, where the person would have to draw it up. So they either have to be able to see pretty well or have someone caring for them or assisting them that can see well. And then the insulin pumps. These tend to work very well for people with type 1 diabetes, although they are using them more for people with type 2, and hopefully there's more in the future for that. The insulin can be short-acting or long-acting, which is why sometimes people are on more than one type of insulin. They would have an insulin that would immediately absorb and affect them, and then one that absorbs slowly over a period of time. Some require refrigeration and some do not, so box inserts do need to be read. A person will be needing diabetic supplies, not just medicines, so these need to be accounted for when prescriptions are handed out for them to go home. They may need syringes, glucometers, glucometer supplies, test strips, lancets, a sharps container, and a variety of other things. So it's just something to keep in mind. All right, next. A lot of people are interested to know more about insulin pumps and where we are with those. I know that they've been touting them as the artificial pancreas, and maybe someday they actually will be, but they're not there yet. The way that they work is they release small doses of insulin continuously at a basal rate to support the body's ongoing need for energy, and a bolus dose close to mealtime can be given to control the rise in blood glucose after a meal. So again, the person has to be eating regularly, has to be knowledgeable about their condition, and has to be committed to monitoring their glucose regularly. For someone who can do that, it can mean fewer injections and it can mean more stable glucose levels, but it's not for a person who is not going to be disciplined in monitoring their own care. Unlike the shots, you have to make sure that the delivery rate stays correct. The tubing can be blocked. The insulin storage chamber can get air bubbles. It can become dislodged. So there are things that a person needs to be capable of doing in order to use these and be safe with it. Newer pumps are being designed to work with other diabetics. This was one that was really fascinating to me, can be set up to wirelessly receive blood glucose readings from specific meters. And so for someone who is savvy with electronic devices, this would work great. So the user could wear it separate from the sensor, and it would allow the user to read glucose trends and graphs on the pump's screen. And one actually includes a feature that triggers the pump to stop delivering insulin for up to 2 hours if the sensor detects that the blood glucose has dropped to a certain level and that the user hasn't responded to an alarm. So a side point here, there's alarms and users need to respond to the alarms and know what to do when the alarm goes off. But however, this safety feature could really help someone who is bottoming out in the middle of the night, because it would shut itself off and would remain off for 2 hours, and that might be just enough time for that person to not receive insulin and be able to stabilize their own blood glucose and not be found by their neighbor in the morning unconscious. So there's more things that are happening, and hopefully they will be refining what's available and things will be better and easier for people to use. But right now, they're not for everybody. And again, the only thing I really want to stress here is that they're for people who are self-disciplined and responsible for their condition. Otherwise, it can be dangerous. Okay, thank you. Next one. So the people involved in caring for a diabetic should be their doctors, which would be a primary care doctor, an endocrinologist, which is the one that would follow the diabetes primarily, especially for people with type 1 or other associated problems, a foot doctor, an eye doctor, and potentially a surgeon if the person gets into a situation where they have wounds, like toe ulcers or foot ulcers. Dietitians, diabetic educators, and many ILCs will have diabetic educators. Pharmacists. I always like to stress pharmacists because they can be your best friend when you're on multiple medications. And sticking with the same pharmacist all the time is a great safety. They will tell you if someone prescribes for you something that will interact. So it's a good thing to encourage people to use the same pharmacist all the time. Wound care center, of course, family, support groups, friends. But the biggest one is self. I can't force someone else, you can't force someone else to eat healthy foods. We can only make ourselves exercise. We can only monitor our own medications. We can only make ourselves quit smoking and drinking in moderation. So in spite of knowing that it's in someone's best interest from my own or your own perspective, that's not what we're all about. As we mentioned before, people need to make their own decisions, but it is important for us to give information so that people are making informed decisions. It's a terrible thing when people make decisions thinking that they're making good and safe decisions because they weren't given all the information. So we always encourage people to make their own decisions and just help them with the research. We want their decisions to be made on accurate knowledge. So inform, educate, encourage, and set a good example. So for the prevention corner, pre-diabetes, just so that you're aware of how big of a problem this is, 86 million Americans 20 and older just a few years ago had pre-diabetes. And this means that blood sugar levels are higher than normal, but not high enough yet to be classified as type 2. So many people, again, have this and don't know it. Without intervention, pre-diabetes is likely to become type 2 diabetes in 10 years or less. So fasting blood sugar of 125 is a red flag, and people who should be screened for prediabetes is anyone who is overweight and aged 45 or more, or under 45, overweight, and with any of the following risk factors: physically inactive, with a family history of diabetes, any of the ethnic backgrounds we mentioned before, Asian American, African American, Hispanic, or Native American, and having those other risk factors as well, or any woman that had gestational diabetes or has given birth to a child weighing more than 9 pounds, anyone with hypertension, high cholesterol, polycystic ovarian syndrome, or a history of vascular disease. So I just want to get that out there because as workmates, we are all concerned about one another, and if anybody has any of these conditions, please see your physician and just get yourself checked out because we want to have you working with us for a very long time. So results of a very large U.S. study released in 2001 showed that even if you're at risk for developing type 2 diabetes because of being overweight, you can reduce your risk by 58% just by a modest weight loss of 10 to 15 pounds. And if we can just change our lifestyle a little by including a little physical activity, sometimes that's enough to do it. Okay, and I think that concludes, and I would open it to any questions if there are.
So if anybody has any questions, feel free to type them in the question box or in the chat box, and I'll read them out for Laura. So Laura, I had a question.
Okay.
when you had mentioned fruity breath, do people with diabetes also sometimes have sweat that has an odd odor to it?
Yes, they can, and that is for the same reason. When the sweat comes out, it can have some of those ketones in it, and it can present itself as either what we would classify as fruity smelling breath, or with the acetone in it, some people may describe it as smelling a little bit like nail polish.
All right, if anybody again has a question that they want to ask without having to type it in, just type in the chat box or in the question box that you want to ask your question, and I will unmute you. Oh, I've got a question here. It says, has D is something related with, is dialysis related to diabetes?
Okay. Dialysis wouldn't be directly related to diabetes. Dialysis is when a person's kidneys fail. So it could be related because of the fact that when a person has diabetes and their blood sugars are very poorly controlled, their kidneys have to work very hard to filter out all that extra sugar. And when that happens, the kidneys can eventually shut down. They tire out. And when this happens, it can lead to a chronic renal failure or even an acute renal failure. So someone with diabetic may end up with renal failure as a result of their diabetes and need dialysis because of that.
Okay, and we have another question. Aspartame and insulin pump. It just says notes regarding aspartame and insulin pump insurance. So if the question is, do insurance companies cover pumps, the answer is yes, but the doctor has to recommend it for obvious reasons. And I'm not sure what the aspartame references to.
Are they asking for where I got my notes about the artificial sweeteners?
Maybe.
If that particular person would like to shoot me an email, I'd be happy to respond to it by that and give them my notes on that.
Okay. All right. Are there any other questions? All right. So if there's no other questions, thank you very much for attending. And as a reminder, we will be having more of these webinars and trainings available. And as always, they'll be available on the NYAIL website if you weren't able to make it at that particular time. I want to say thank you to Laura for a very good and comprehensive training. And we'll all be talking soon. Thank you, Laura.
Welcome. Bye.